Welcome to another intensivecarehotline.com live stream. My name is Patrick Hutzel from intensivecarehotline.com and Intensive Care at Home. I think I'm a minute early today, so we'll just wait for a couple of minutes for people to come in and join us here on this live stream today. Today's topic is 10 things a quality ICU will do, and also want to answer your questions around any questions you have if you have a loved one in ICU. So that's the topic today. 10 quality things, or 10 things a quality ICU will do. And I want to answer your questions as well that you have around this topic or any ICU related topic if you have a loved one in intensive care or if you had a loved one in intensive care. So before we dive into today's topic, you may wonder what makes me qualified to talk about this topic. So I'm an intensive care nurse by background. I have worked in intensive care for over 20 years in 3 different countries. I have also been consulting and advocating for families in intensive care all over the world for nearly 10 years now, and I'm also the founder and owner of Intensive Care at Home, where we provide intensive home care nursing for predominantly long-term ventilated adults and children with tracheostomy, but also non-invasively ventilated adults and children at home on BiPAP, on CPAP. We also provide home TPN, central line care. Anybody that needs an intensive care nurse at home, that's where you should come to at Intensive Care at Home. Now, today's topic though is about intensive care in hospitals, and again, in case you wonder what makes me qualified, with having worked over 20 years in ICU in 3 different countries. I've also worked as a nurse unit manager for over 5 years in intensive care. Actually managed 2 separate ICUs, and I've also worked as agency. So I actually have not counted how many ICUs I've worked in over 20 years. There would have been dozens, including agency work in different countries. I haven't really counted. I would believe that I would have worked at least in 2 dozens ICUs over in 3 different countries. I haven't counted, but plenty. So that's a bit of background, and because I'm talking to families in intensive care every day all over the world, that means I'm talking also to ICUs directly. So I believe I have good insights in terms of what determines a good ICU and what determines an ICU that's not so good. Just some housekeeping issues. If you have questions regarding to today's topic, type them into the chat pad now. If they're not to today's topic, I will get to your questions at the end of today's presentation, and then you'll also have the opportunity to dial in live on the show. I'll give out the numbers at the end of this presentation. So let's start with what makes a good ICU and what do they do so they can show to you that they are actually good. The first and most important thing is there's open communication. Well, you'd think that goes without saying, but the reality is the last 2 or 3 years with COVID in particular, families have been cut out of ICU. They've been cut off. Their loved ones have been in ICU without any family support. Yes, people have been able to dial in via an iPad and via WhatsApp and via Skype and via Zoom, but that doesn't replace face-to-face interaction. It doesn't replace open communication. From what I've heard, over the last 3 years with COVID, most families have only been giving sparing updates over the phone, couldn't get hold of doctors. Nobody was taking care of informing them regularly and transparently. It's been a shocker, But even before COVID, most ICUs have not been open and transparent. And, open communication is a 2-way street, that all questions are getting answered, and that you can ring up the ICU and you can actually get a doctor on the phone, assuming it's sort of daylight hours, but even nighttime hours, you should be able to get an ICU doctor on the phone 24 hours a day. and there should be open communication. And that leads me to point 2. Answer questions without any prejudice. I believe a lot of families that come to us, they feel judged. We don't judge here. We're just trying to help people. That's all what we are here for. We're not judging you on what you want for your loved one. You want the best outcome, and I'm not judging you for that. It's my goal as well to get the best outcome for your loved one, and that outcome might be your perception of that outcome might be very different to the perception of the outcome of the ICU, but doesn't matter. They should answer all of your questions without any prejudice. You and your family member are the most important part in this, and not the ICU. The ICU makes it about that they're the most important part of having your loved one in intensive care. They make it all about them. They make it about, not that they tell you explicitly, but implicitly, they need to manage their beds, they need to manage their budget, they need to manage their staff, they need to manage their research funding that they're getting in for the research they're doing in the ICU that often brings in millions of dollars, So there's all these hidden agendas that you have no idea about, and that's why you're often harshly judged on what outcomes that you want for your loved one. That leads me to number 3, giving you hope. Giving you hope. Life is nothing without hope. You have to have hope in life, otherwise it's probably not worth living even. And what do you get? You get negativity from ICU teams, you get grief, you get doom and gloom, and you get the talk about your loved one is not going to survive, and if they do survive, they won't have any quality of life. It's all doom and gloom, it's all negative. A good ICU will tell you what's really realistic without their agenda in mind. They will encourage you in getting your loved one out of ICU alive, even if it means the quality of life is not as good as you would have hoped before. But they will still help you achieve that goal. And if you're watching this video, you're probably already knowing that most ICUs are not trying to help you achieve the goal. They're trying to be obstructive. Again, they're trying to push their agenda, not your agenda. And when I say give you hope, the synonym for that is they work with your agenda and not with their agenda. And they stop judging you and trying to make you feel bad by telling you things like, well, if it was my mum, if it was my dad, I wouldn't want that for them. It doesn't matter what they would want for their mum or for their dad or for their spouse. It's you that matters. It's you and your family that matters, nobody else. Next, number 4, they don't judge you about your wishes. Again, comes back to answering your questions without prejudice. Nobody wants to be judged for their views, for their points of view, for the wishes they have. Nobody wants to be judged for that. And yet that's what ICUs often do, again, to get their agenda through. Their agenda is to manage beds, to stay in control of the narrative. That's what it really is. They want to stay in control of the narrative, of the frame, right? And you have your own narrative. You should not concern yourself with the ICU team's narrative. Your narrative is your narrative, and that is all that matters. And you should be very persistent with the outcomes that you want. And that's, a lot of families in ICU get discouraged by the obstacles that ICUs put in front of them. And you should not be discouraged. That's the biggest mistake you can make, by getting discouraged from the obstacles they're putting up in front of you. Their agenda is so important to them, again, managing bed flow, managing staff, managing finances, managing the narrative that is important to them, right? Again, you should not concern yourself with that. You should focus on your narrative, and you should focus on your outcome that you want. Everything else does not matter. Next, a good ICU will not judge you about what you or your loved one finds acceptable for quality of life, right? So what do I mean by that? Again, you would have, if you watched any of my videos or read my blog, you would know that, even if there's hope from the ICU team perspective, you know that ICU says, yeah, even if your loved one survives, they won't have any quality of life. Well, that's a perception, not more than that. It's just a perception. And what's your perception? What's your perception about quality of life? What is important for you? What is important for your loved one? Do they have an advanced care directive? Right? So it comes back to what you want, not what the ICU team wants. Don't let anyone judge you about what outcomes you want. You know, the best example where I can illustrate that is, for example, the J.I. McMahon case in 2013. J.I. McMahon at the time was a 13-year-old teenager having had a tonsillectomy in a hospital somewhere in California in the US. Unfortunately, the day after she had surgery, she had a massive bleed and she ended up in a cardiac arrest with brain damage. You know, she had prolonged CPR and it took a long time to get her back. Anyway, in the end, they did get her back. She had dramatic brain damage. The hospital declared her brain dead, and the family challenged that in front of a court, saying even if she was brain dead, well, we still think she's alive. It's just her brain that's dead. You know, everything else, all other organs were working, and the family challenged that. Now, I am not a lawyer here. I'm not an attorney. Can't give any legal advice. But the outcome of the situation was as follows. The family managed to transfer their daughter, J.I. McMahon, with a tracheostomy to New Jersey in the US, because in California, when someone is declared brain dead, they are also legally dead by law. Not the case in New Jersey. In New Jersey, someone is not legally dead if they are considered brain dead, just as the family requested at the time that, well, just because they think, the hospital thinks J.I.'s brain is dead doesn't mean she's dead, right? So there are different schools of thought around what is considered as dead. Oh, who am I to say that? I don't know your beliefs. I don't know your religion. I don't know your spiritual belief, your cultural beliefs. I don't know anything about that. I can only talk about what I believe. And I believe in variety. I believe in that everyone has the right to decide what they choose is acceptable for them. That leads me to the next point, which is, no judgments about quality of end of life. Again, what does that mean? If someone is dying, is in palliative care, or, what should that look like? Does someone want to die in intensive care? Are there any other options? Like with our service intensive care at home, we're also providing palliative care at home, and end of life care at home. So, nobody wants to die in an ICU. It would be so much nicer to do it at home. So, and again, a good ICU will help you achieve all of that. And that leads me to the next point. They actually give you options. They give you options to choose from. Right? A quality ICU will lay options on the table and say, here's what we can do, here's what we believe is best, here is what we believe will work, here is what we think won't work. They put it on the table for you, and it's a bit like, if you go into the supermarket, you can choose from 25 different groceries. And ICUs are different in that aspect, but a good ICU still gives you choice. They still give you options. They lay it on the table and they say, hey, if we can't help your loved one here, maybe another hospital can help you. Let's look at a transfer. But very few ICUs do that because, again, they want to stay in control of the narrative. They want to stay in control of the funding that comes in, of the money flow. They want to stay in control on what's being perceived as a good quality of life, what's being perceived as a good outcome. They want to stay in control of that narrative, whereas you and I know, well, it's not up to them, not up to me, not up to anyone but you to make that determination. What is good for you, what is good for your family. And ICUs, a good ICU will help you to achieve those objectives one way or another. Next, they share treatment options with you in a transparent manner. They will share transparently with you what treatment options are there. Best example, again, last few years, COVID. Not only during COVID, but it just highlighted it to me how literally ICUs are not transparent and withhold treatment options. So a lot of COVID patients in ICU ended up with ARDS, acute respiratory distress syndrome, also known as lung failure. Now, first-line treatment for lung failure is often obviously mechanical ventilation. During COVID, it was remdesivir, steroids, and even before COVID for ARDS, you would definitely do the steroids, antibiotics, obviously COVID is a virus. So, and then if that doesn't work, you start with high-frequency oscillation ventilation. You might start with prone position, and if that doesn't work, then you would go on to ECMO. Now, a lot of clients of ours had their loved ones, prone position, and that didn't work. And no ICU told them about ECMO, right? And by not telling them about it and by not even elaborating that option, it was often a death sentence for our clients, So and then we informed them about ECMO being an option, and they had no idea that it was an option, right? So whilst ECMO beds are very limited, and ECMO beds were very limited before COVID, it was literally very few patients that needed ECMO ended up on it, and that's why the mortality rate was so high as well. Not the only reason, but one of the reasons from my perspective. So, other things that we're finding all the time, not only with ECMO, but when it comes to cardiac failure or lung failure in particular, it's very nuanced, again, during COVID, for example, families had also not been informed about that. If prone position doesn't work, if ECMO was not available, is a lung transplant an option? Well, ECMO would have been needed for a lung transplant as well most of the time, not all the time, but in some instances, families had no idea what courses of action would have been available to the ICU. Again, it comes back to me saying the biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. And that is the biggest challenge that I've seen over and over again. Other thing that we've seen is, again, when we look at medical records, when we talk to ICUs directly, we are finding that, again, treatment options are not laid on the table, right? After cardiac arrest, does someone need to go on ECMO for cardiac failure? Again, do they need to be listed for a heart transplant, for a lung transplant? What needs to happen to bridge them successfully? How long could they stay on ECMO? Do they need an LVAD? Do they need an RVAD? Those are very complex issues, and families have no idea because they simply lack the insights into a highly specialized area in intensive care. Next, they are looking for options for you, whether it's a transfer to another hospital that's more specialized on maybe ECMO, on maybe burns, there some hospitals have real specialties that other hospitals don't have, they will help you for a transfer. They will help you to transfer you to services like intensive care at home, which we run as well, right? You should check out intensivecareathome.com, where we can help you to take your loved one home from ICU if they're long-term ventilated, if they're on TPN, home TPN, we can provide home TPN. We can send you ICU nurses into the home for mainly long-term ventilation and tracheostomy, adults and children, said home TPN, but also non-invasive ventilation, such as BiPAP, CPAP, seizure management. We do some of that at home. So, a good ICU will help you with that because they wanna see you win as well, right? But a lot of ICUs, from my perspective now, are very nihilistic. They are they're not interested in getting good outcomes for you, and they believe that death is a good outcome. They really do believe that, and I disagree there. We're all going to die, and we can all accept that, but the reality is that by having such a nihilistic point of view, such a negative point of view, That's not going to help anyone. So good ICU will help you looking for options, again, whether that's treatment, whether that's looking for another hospital, whether that's for intensive care at home services, and at the moment, just as a disclaimer here, depending on where you're watching this from, at the moment, we are predominantly providing intensive care at home services in Melbourne, Sydney, Brisbane in Australia, but also in Adelaide and in Perth. You can contact us on one of the numbers on the top of our website. If you are in the US, and you are looking for intensive care at home, we're not there yet. However, we might be able to help you by setting you up with some other services. You should definitely contact us as well. And I've mentioned this before, that an ICU will help you achieve your goals and not sell you on a goal, right? The number of times that I've been in family meetings when I was in ICU, where the ICU quote unquote sold a family member that death is a good outcome for their loved ones, is, I've stopped counting. But by the same token, there are probably some situations, but not very many, where death might be a good outcome if someone is unduly suffering, but then again, what is unduly suffering? What is it? Some people have a higher pain threshold than others. It's all in the eye of the beholder. Right? Next, they do not use family meetings as a vehicle to pressure you, because that's what's often happening in ICU, that families are getting pressured. They get called to family meetings, and in those family meetings, they get told the negative news, the bad news, and then they get pressure to make decisions by tomorrow at 5 o'clock. You have to make a decision whether your loved one should have palliative care or hospice care or have a tracheostomy. They will always put pressure on, and they will ask them to family meetings saying, hey, tomorrow at 1 o'clock, we've got a family meeting. And if our clients come to us and say, hey, ICU told me tomorrow at 5 o'clock, there's a family meeting, I need you to come. And I just go like, if they would ask you to jump off a bridge, would you jump off a bridge? And I'd say, why would you go to a family meeting? My advice there is always get a written agenda, and then you decide whether it's worth your time going there or not. I would never go into a family meeting without a written agenda. I would never go into a family meeting in ICU without professional representation, i.e. have myself there. I can ask the right questions. I know what they say in intensive care family meetings. I know what they will say. I know how they will say it. I know what they won't say, and I know what questions to ask, and I know how to steer the meeting in the right direction so you don't get walked all over. Again, like I said before, especially in family meetings, but even outside of family meetings, they want to stay in control of the narrative. And if you don't know how to manage that dynamic, they will stay in control of the narrative. It's very important. That you stay in control of the narrative. And you can only stay in control of the narrative if you have professional representation, if you have someone like myself who understands intensive care inside out, who speaks the intensive care language, who can talk to the doctors on their level. That's the only way you can manage the narrative. Okay, so next, I want to talk about, so that's pretty much my list in the 10 things a quality ICU will do. It was actually more than 10 things, but next week I want to talk about 10 things an ICU does that's not of quality, and again, another thing that sort of, probably my last point in terms of the things that the good things that a quality ICU will do. I've worked in some ICUs where, staff were getting bullied, doctors and nurses, and it showed up in outcomes in patients, I believe, because there was high staff turnover, staff morale was very low, and the outcomes of patients became poor, and families were being bullied, and you have to run from those ICUs a million miles. So, when I say about a quality ICU, they are the good ICUs that I worked in where you know, everyone was sort of valued, whether it was patients, families, staff, you know, they're good ICUs. But, you know, I also believe that even the good ICUs in the last 2 years have suffered because of COVID, because of high staff turnover, staff burnout, you know, the way staff have been treated, vaccine mandates, some highly qualified staff lost their jobs because there are vaccine mandates either hospital imposed or imposed by local governments or by departments of health, you name it, you know. So yeah, so those are the points that I wanted to bring home today. Now, I now want to focus on if you have any questions. Yeah, if you have any questions, please type them into the chat pad now. Or if you want to dial in live on the show, you can do that. You can dial in if you are in Australia, you can call it live into the show now on 041 094 2230. That is again for our Australian viewers, 041 094 2230. If you're in the US, please dial 415 915 0090. That is again 415 915 0090. If you're in the UK, please call us on 0118 324 3018. That is again 0118 324 3018. I'm looking forward to hearing from you either over the phone now or type your questions into the chat pad. Now, while I'm waiting for your questions to come through, next week I want to focus on the 10 negative things that ICUs do, or that low quality ICUs do. I mean, there's a whole list of things but I do want to keep it positive. And, you know, I also can't stress enough that there are a lot of good things happening in ICU, you know, and some people might come to my blog or to my videos and say, oh, this is all negative. The reality is that people only really reach out to me when things are negative. You know, they don't reach out to me when things are really going well because they don't need my help, you know. And also big shout out to my team in the background. You know, I'm not a one-man show. There are people working with me in the background that are helping me achieve those amazing outcomes for our families in intensive care. So, so yeah, next week I want to focus on the negatives. Now, in the meantime, you know, I'm waiting for your questions. If you have any, please shoot them away. You know, I do those YouTube live streams once a week. I try to maybe get a second one in a week over the next few weeks, depending on how much time I've got. I really enjoy doing them. And, you know, I usually choose a topic that is, you know, relevant to the audience. I choose the topic around the questions that we're getting. I choose the topics around when I talk to clients on a day-by-day basis, you know, what is important for them, you know, what questions do we get over and over again? Is it then I know it's definitely worth doing a longer video or a live stream where people have the ability to ask questions. Now, some of the, and how can you actually, probably I should, you know, focus on that as well. How can you make a judgment quickly whether you are in a quality ICU or not? I think you can make a judgment pretty quickly right from the start, and I'll tell you why. I do believe you just need to listen to your gut. You know, start listening to your gut. What's your gut telling you? Are the people nice? Are they friendly? Are they easy to get hold of? Are they easy to talk to? Are they trying to put obstacles in front of you? You know, again, are they trying to judge you because of your points of view? Are they trying to dismiss you? You know, another good thing that an ICU is doing is they explain things to you in your language so that they don't focus too much on clinical and medical terms. They break it down to you so that you can understand what's really happening. That's really important. You know, like what I'm trying to do here. I'm trying to take high-level information, clinical information, medical information, complex information, and break it down in terms that are easily understandable for someone that hasn't worked in ICU for 20 years, you know. and look behind the scenes of what I've seen over the years and what I'm seeing now when I talk to families and to ICUs. I'm really trying to break this down for you in easy to understand words, and if ICUs stay high level and only talk clinical jargon and almost make it look like, well, I don't want you to understand it, because then I can definitely stay in control of the narrative. That's another red flag. That is not the sign of a quality ICU. Definitely not the sign of a quality ICU. You can also get a feel for if an ICU is very hierarchical, and that is often also a sign that they're very political. If they're sort of saying, oh, I can't talk about this today, I've got to ask the nurse in charge, I've got to talk to the nurse manager, I've got to talk to the medical director, I've got to talk to this specialist. That is also not a good sign, because it usually shows that ICUs are political. And if they are political, it means patient care is not the center of, it's not the focus. The focus should be patient care, not politics. But unfortunately, after having worked in hospitals for over 20 years, pretty much all hospitals are political, and patient care suffers because of it. Patient care should come before politics. Hi, Helene, how are you?
I'm okay. How are you, Patrick?
I'm really good, thank you. Thanks for dialing in. Can you hear me okay?
Yes, I can. I'm going to talk about, I have a question concerning a time you spoke in the past about euthanizing patients, that is forbidden. And so I recently got my late mother's medical records from the LTAC, and I was going through it, and plus I witnessed it myself. I witnessed where the hospitalist changed my mom's water consumption that was she had also done a peg tube while she was there. And they lowered her water consumption only down to 6, I want to say, if I can remember, 60 milliliters, I think, for every 4 hours, which was, I think it went down from 250 all the way to 60. They never even told me about it. That number might be incorrect, but I'm thinking it was about that. And once I caught it, because I started noticing her urine was looking very dark. Also, in LTAC, how they're supposed to change out, if the patients have a Foley, change out the old the prior hospital products and put in their products. They did not even do that until 11 days after she had. Well, let me see. She went in on the 23rd of March the 28th of 2016, and I caught it on 4/11. And I didn't even know it was they did not change out the Foley. I just started questioning why her urine was so dark, and then that's when the nurse said, "Oh, they didn't even change out her Foley. That's not our Foley bag." And another thing I found out, they totally stopped the water and was giving my mother saline in her pack tube. Have you ever heard of that before?
Yes, I have. And if they stop the water and they've given her saline instead, I would argue they might have wanted to correct the saline. When I say saline, they might have wanted to correct the sodium in her blood level, if that makes sense.
No, wait a minute. They were giving it to her in her peg tube.
Yeah.
No IV.
Yeah. No, I hear what you're saying. At the end of the day, it's salt water. And if her sodium, for example, was low, they might have still corrected that via the peg tube. They might have done. Maybe they didn't want to put an IV in.
She had a sensitive one.
Then it doesn't make sense.
So,
Then it doesn't make sense. Then they should have given it via the central
exactly.
line.
Right. And the other thing is when they was discharging her to go home, the doctor, because when I caught it the first time, they did change back and start giving her water again. And then when she was being prepared for discharge to go home, he changed her back for saline. He totally discontinued water, and he wanted her to have saline for the rest of her life. And I said, well, would you write a prescription for it? You know, so Medicare can pay for it. And he was like, well, no, Medicare doesn't pay for anything you can get over the counter. And I said, well, then instead of giving her saline, can I give her alkaline water? You know, and has electrolytes. He said no. He totally discontinued water and wanted her to be on saline for the rest of her life. He also changed her from Isoplus to Soprina. And Soprina supplements for people with stage 3 and 4 kidney failure. Have you ever heard of that? And of course, she had a colostomy that she had gotten from an injury from another hospital back in 2012. And come to find out, I was told that somebody who has a colostomy should not be even being given Soprina because it has fiber in it. And
how do you spell that? Soprina? How do you spell that?
Suplena, Suplena. It is, I think Abbott is the manufacturer.
S-U-P-L-E?
S-U-P-L-E, Suplena, N-A.
N-A. I just need
Yeah,
to, oh yeah, it's Nep.
It's a feeding
Yeah.
supplement.
Just give me a second. I just need to,
Okay.
it's also known as Nepro. This is a non-dialyzed patient. Yeah, it's a nutrition for chronic kidney disease patients.
Right, and she didn't have kidney disease. And plus, when she was, prior to her being discharged from LSAC, the hospital did not want to set up follow-up appointments to any of her specialists. I had to really advocate, say, well, she has a PCP, and she has a pulmonary doctor. But he didn't even, but I said she needs to be seen by a neurologist because she had suffered brain damage at the prior hospital, and she had multiple strokes and heart failure. He did not want to, set up a follow-up appointment for her to be seen by any of those doctors because he was trying to cover up the injury that the other hospital had caused her. If a patient has had a heart failure in a hospital, when you think they should be going to a nursing home that helps with someone recovering from heart failure, when you think?
So I'm not quite following now. So I understand obviously the concerns around the nutrition. I understand they've reduced the nutrition significantly. Your first question
And water
and water
hydration.
and your first
Water.
right, and your first point was that you were worried about that this might have led to euthanasia. Did I understand this correctly?
Yes, I do.
Right.
Yes, when you look at all of these adverse plans of care that was done, which was adverse, to me, it's a form of euthanizing someone because you're depriving them of water, you're depriving them of food because you are, and also this patient have suffered multiple iatrogenic induced injuries like hypoxic brain injury, multiple strokes under their
Yeah.
care. He also got hepatitis C, MRSA pneumonia, as well as heart failure.
Yeah, I see. So look, I don't have enough information in terms of, you know, how far did they reduce the water and how far did they reduce the nutrition. If your mom lost weight because of that, and if your mom's, you know, electrolytes changed because of the water reduction and the food reduction, 100%, you know, if you think that led to her dying prematurely, then, you know, you should probably investigate that further. You know, that there's definitely an element
It's
of
being
that.
investigated. It's being investigated with HHS OIG here here in Washington. It's under investigation because um, I don't want to get into all of it, but yeah, there was a lot of foul play. There was a lot of foul play. And to send somebody home that suffered severe brain damage, toxic encephalopathy, and also once I got her home and I took her to the PCP, the PA discontinued her Eliquis permanently, and I said, well, shouldn't you wean her off of it or give her another medicine to help her, or even restart her on baby aspirin? And they said no. And I found out later, after my mother passed, with Eliquis, you're not supposed to abruptly stop or discontinue, taking Eliquis. And they knew she was at high risk because she had a stroke, multiple strokes in the hospital that they concealed from me, and a heart attack.
What do you know what was written on the death certificate of your mom?
Yes, they put she died from dementia, and then there's another section over there that said she also suffered aspiration pneumonia, and what they were trying to frame me for Munchausen by proxy, but she did. Only time she had aspiration pneumonia is when she would be in the hospital and they give her excessive fluid overload and having her laying flat and giving her all these drugs that made her vomit. And that in itself, if it go down into her lungs, could cause aspiration pneumonia. Also, another thing I witnessed as a pattern, an adverse pattern. A lot of times when they would bathe her, and there are other times just for doing. They will lower her bed, tilt her bed where her head was down and her feet was up. And then, so can you imagine whatever toxins are in your stomach can go and come down, can flow up to in your throat, and then maybe, I got them to pull it back up. When it went back down, it could have easily gone into her lungs, but she did suffer multiple aspiration pneumonias in the hospital, but they were trying to shift blame on me, make me their scapegoat, the doctors. Unfortunately, I was there to see all of the egregious malfeasance and malpractices that they were doing, because they make money when they can get you on the vet, and it was intentional. Her medical bill at this one particular hospital was $1,400,000. And they got paid the full amount. It wasn't even the contract of Medicare, where it's supposed to be lower. They were paid the full amount by Humana.
Right.
And they were giving her bukus of opiates, lethal amounts of opiates for I mean, even before she was ever on the vent, or even pre them doing a bump discharge, trying to get her out of there once they knew she had septic shock, and heart failure. They were trying to either get her transferred to another, like a LTAC, or send her home. and they were concealing all of this from me. But I was there, and I knew something was wrong. Plus, I had the thing you put on your finger, opposite that, you could check your O2 sats and your heart rate. And when I knew her O2 sats was 69 that morning on room air, because she had pulled up the nasal cannula out of her nose. And they was discharging her without even checking her to see what her O2 sats on room air. And she normally did not have oxygen, have to use oxygen every day. Only time my mother would have to have oxygen if she had an infection, a pneumonia, which is an infection. Other than that, my mother O2 sats was around 98 to 100.
Right. Look, I have never heard, Helene, that someone is dying of dementia. I've never heard that. That doesn't mean it doesn't happen, but it doesn't make sense that the cause of death is dementia, unless someone has a fall, hits their head, because they're dementious. But even that would be a fall, not necessarily dementia.
Exactly. And which also, it was a big red flag, and that is also being investigated. I mean, I was able to fill in like an amendment to her death certificate, because it was all part of the investigation. The fortunate part of all of this, that from what happened to her back in 2012, where she was abused, exploited, medically exploited, and ended up on a ventilator, and that's how she got ARDS and other problems that they concealed from me as well. I reported it to HHS OIG in Washington, and they started their own investigation, but they kept it confidential because they know these things are happening to vulnerable patients. And my mom was, and I was a case study, because I was taking care of her full time. Also, the stress of taking care of a loved one who had gotten septic shock in the hospital, all kinds of infections, hepatitis C, MRSA. She was medically tortured. It's like, if you're inducing illnesses for profit, that's criminal.
Right.
And that's exactly what they were doing. And even though I don't have a clinical background, I do have really keen discernment, and it's just common sense cause and effect, where they were giving her excessive fluid overload, and surgery she didn't need back in 2012, putting drains on the diverticulitis abscess, instead of the normal standard is to give a patient antibiotics and put them on a 72-hour. That was never presented to me for my mom. And I was a dual power of attorney, which means it includes health care. I made decisions for her, and I was being coerced to sign uninformed consent. I was not allowed to get a second opinion. It was a lot went down from 2012 to 2016. I saw a lot, and my mother suffered a lot. It was horrific.
Right.
She was strong, and God was truly with her, because from what she endured, God had to be with her. Because after she had gotten ARDS, my mother, on a stress test, when I was taking her for pulmonology, she couldn't even blow a match out. But yet,
right,
her O2 sats would be 98 to 100, and she didn't have an infection. And and also, by giving her less water, it was also causing her to have a lot of UTI infections. And I found out too that many times they would give her the incorrect antibiotic, and that's another thing so important. It's good to know what is the bacteria, or what it is, to make sure they're getting the right antibiotic. Because many times my mother was not even getting the right antibiotic, or even when she had pneumonia that landed her in the hospital in 2016, they knew she was allergic to something, and they gave her they gave her, they gave her Cefner, and it's the same makeup as penicillin because she was allergic to penicillin, and we're not giving her a Z-Pack for the early stages of pneumonia. And they knew she was going to end up in the hospital. And that's, you remember I talked about how her carbon dioxide had dropped. She couldn't, well, I guess it was high, air was high, but she could not blow it out of her lungs, which ended her in the hospital on January the 7th of 2016. And she ended up in the hospital for 3 months, a little less than 3 months at one hospital, and then she was, I had to do an emergency transfer to get her out of there, and that's how she ended up in the LTAC, because they did not want to decannulate her.
Right.
Yeah, so it was a lot of foul play.
For sure,
But
for
it's
sure.
When, but the sad part about it, they were trying to blame me for make me their scapegoat and trying to blame me for Munchausen syndrome by proxy. For aspiration pneumonia. But in case somebody else want to ask me any questions, I'm going to hang up. But thank you, Patrick. I just wanted to.
Yeah, no, it's great. It's great that you share that, because our audience can hear what to pay attention to. It's important that you've done a lot of research over the years, obviously, with this situation. But the biggest challenge that I can see when I talk to families, they don't know where to start, and that's understandable. It's a very complex arena. I mean, you've now dealt with this matter for years, and you've looked into it in much detail.
Yeah, for me, I have to truly give the credit to God, because like you always say, when you don't know what you don't know.
That's right.
So how do you know what questions to ask? And I'm that person. But I paid attention to my mom. Plus, I saw a pattern of this excessive, giving excessive food overload. I saw this pattern of them giving her all kinds of drugs and opiates, but not telling me what they were. I giving her overdoses of antibiotics that can create a superbug and cause her to have immune deficiency. And I started seeing these patterns. That's when I saw the effects of it and how they wanted me to consent to put her on the vet, and the money that they make with a patient in ICU, I knew it was driven by malfeasance malpractice. And truly God was guiding me, because when they would not tell me what medications they would give her, I just had to stop asking. It's like the Holy Spirit, and He said, stop asking. This when they carry the package, open it, and they put it in the truck. Just take that package and put it in my briefcase. And when I was in a good position of where I could focus in on it and look it up, which actually was after she passed, but taking care of my mother with all those injuries and strokes and everything and brain injury, and she couldn't talk anymore. I was the sole person taking care of my mother full time, 24/7, and even in the hospital, taking care of her 24/7. And they would many times try to get me to leave her, because I was reporting things and asking questions, and they didn't like that.
For sure.
And plus she had, what you call it, she had dementia that was drug induced. My mother really had a great memory, but she was abused in a hospital in Memphis. So literally I had to rescue my mother from my own sibling back in 2010. And then I saw how she was being exploited in the hospitals here, and it's amazing. They make plenty money off these drugs.
For sure.
I mean, it's so important to be informed. And a lot of times they lie to me, or they dismiss me, or just let stuff fall through the cracks, or just lie and say, "Oh, that was resolved when it wasn't." And a lot of times I found that even with UTI infections, they would say, "Okay." Many times I had to advocate for the request for UTI infection in the hospital, and sure enough, she had it. And then my question is, I think it should be another test afterwards to make sure it's cleared up. But many times it wasn't cleared up, because a lot of times they were giving her the incorrect antibiotic that wasn't cleared up. And by continuing to give somebody antibiotics, you're creating a superbug where
For sure.
eventually their immune system won't respond to anything.
Yeah. No, you're right. You're right. Yeah. Okay.
That's what happened to my mom. But okay, thank you.
Thank you so much for sharing, Elaine. Thank you so much for sharing. Take care, and I'll talk to you next time. Thank you.
Okay,
Bye-bye.
bye-bye.
Bye. So the line is open now for somebody else to call in. Thanks, Helene, again for sharing. The line is open again now for others. If you want to ask a question, dial in. I've got another 5 minutes left, but then I've got to wrap this up today. Type your questions into the chat pad or call on one of the numbers that I shared before. Now, if you have a loved one in intensive care, go to intensivecarehotline.com, call us on one of the numbers on the top of our website, or simply send us an email to support@intensivecarehotline.com. Also, have a look at our membership for families in intensive care at intensivecaresupport.org. If you need a medical record review, go to intensivecarehotline.com as well and contact us. If you have a loved one in intensive care and you want to go home with ventilation, tracheostomy, non-invasive ventilation such as BiPAP, CPAP, home TPN, anything that requires an intensive care nurse at home, you should contact us at intensivecareathome.com. Currently, we are servicing mainly Melbourne, Brisbane and Sydney in intensive care in Australia, but we have, if you're in the US, you should definitely contact us as well. Like the video, comment below what you want to see next. Share the video with your friends and families. There will be another YouTube live next Saturday, 8:30 p.m. Eastern Standard Time. Or it might be 7:30 because we're going into daylight saving next week. You'll see the exact time on my YouTube. 10:30 a.m. Sydney, Melbourne time next week. Like the video, click the notification bell and comment below what you want to see next. And thanks for watching, and I will talk to you in the next few days. Take care for now.